यहाँ से भी स्टार्ट है ना. Okay, so in last class we have discussed asthma. So under 5 V'ers we have discussed in last class. Under 5 V'er is somehow different from 6 to 11 and more than 12 years of age group. More than 12 is like adults. So under 5 V'er the problem is more than most of the under 5 children usually outgrow their asthma by the age of as they reach adulthood. So that's why the labeling of asthma in under 5 is not a classical term. So we are using under 5 V'er with low probability of asthma, some probability of asthma and high probability of asthma based on the symptoms which we have discussed last class. And since asthma is a heterogeneous disease with varying features like wheezing, chest pain and breathlessness, so that can vary, and all because of chronic inflammation, hyperresponsiveness and bronchial obstruction. So and then we have started from 6 to 11 age group we have discussed ARPIT. So this ARPIT, the classical history we have taken, and as we can see there is no history of fever, does not have fever, and frequent sneezing. Father has frequent sneezing episodes. Recurrent cough and nocturnal symptoms are also there. Activity limitation was also there. Trigger induced symptoms, cough when exposed to dust. Seasonal exacerbation usually bad in winters. And bronchodilators के साथ relief history was also there. On examination, he has bilateral scattered wheeze with no retraction and normal saturation. So for assessment of level of control, the classification is controlled, partly controlled or uncontrolled, and 4 symptoms we have to look for. All these are very simple, like daytime symptoms more than twice per week and need for reliever rescue treatment more than twice per week. Both are almost the similar line. Daytime symptoms more than twice per week or need for bronchodilation more than twice per week. Then the limitation of activity, if he is not able to play for a long time or he cannot do exercise for a long time and he gets breathlessness, then these are limitation of activities. Nocturnal symptoms or awakening at night, again these are the symptoms which we have to ask for, especially in the last 1 month. What is the level of control in this child, we have to ask for based on these 4 symptoms. If all these symptoms are not there, then it is a well controlled asthma. If it is a 1 or 2 symptoms out of these 4, 1 or 2 symptoms are there, then it is a partly controlled. And if all the symptoms 3 or 4 of these are there, then it is uncontrolled. Uncontrolled definitely we have to step up, partly controlled also we need to step up. So that depends कि हमें management को कितना escalate करना है. So this is the GINA guidelines for children 6 to 11 years with the diagnosis of asthma. Again we have to confirm the diagnosis and look for the inhaler technique and adherence, child parent care preferences and goals we have to look, we have to ask for, and then based on the symptoms, if symptom is less than twice a month, then just low dose inhaled corticosteroid whenever he is taking bronchodilator. Whenever he is taking MDI salbutamol, at that time we can give low dose budesonide also. So this is a step 1 if the symptoms are less than twice a month. So this is like a intermittent asthma. So पहले intermittent asthma में क्या करते थे, SOS MDI salbutamol inhaler देते थे, but the recent GINA guidelines से जब भी देना है salbutamol आपको inhaled corticosteroid के साथ देना है, especially in more than 5 years of age group. So this is to prevent long term response. So now the step 1 for intermittent asthma like symptoms, we have to give low dose inhaled corticosteroid whenever we are giving salbutamol. Step 2 means if the symptoms are twice a month or more but less than daily symptoms, then we have to give continuous means daily low dose inhaled corticosteroid budesonide. Step 3, this is the preferred method and this is the other controller option. This is the preferred controller option and this is the other controller options. So we will talk about preferred one, and reliever is as needed SABA. As needed SABA means short acting beta agonist, that is salbutamol, or low dose inhaled corticosteroid plus formoterol. Formoterol is long acting beta agonist. So in the step 2, like if the symptoms are twice a month or more but less than daily, we have to give low dose inhaled corticosteroid and as needed SABA. As needed salbutamol we can give, or we can use low dose inhaled corticosteroid with formoterol, means Foracort we can give. Now coming to the step 3, like symptoms most of the days or waking with asthma once a week or more. Almost उसको हर दिन symptoms रहता है, night time awakening भी रहती है उसे. Then we have to start low dose inhaled corticosteroid and long acting beta agonist. So here what is the change? The symptoms are almost daily, that is the persistent symptoms and with night time awakening also. So we have to start with budesonide with formoterol, and the same we are using for as a reliever also. So same thing we can use for reliever, or we can use MDI salbutamol also as a reliever. So preferred one is always use inhaled corticosteroid whenever you are using reliever. Now the step 4, like symptoms most of the days or waking with asthma once a week or more, and lung function is also deteriorated, there is low lung function, and most of the day symptoms are there, night time awakening is also there, lung function is also not good. So here we have to use medium dose inhaled corticosteroid. Just we have increased the dose of inhaled corticosteroid budesonide from 200, 400 to 800. And then maintenance also we are using the same low dose inhaled corticosteroid plus formoterol. So this is called maintenance and reliever therapy. Means maintenance के लिए भी same use कर रहे हैं, reliever के लिए भी same use कर रहे हैं. For budesonide plus formoterol. Formoterol is long acting beta agonist, budesonide is steroid. So we are using same inhaled combination Foracort, that is the trade name, we are using for both as low dose as a controller, as a reliever also. This is called MAT, maintenance and reliever therapy. This is the new terminology in the GINA 2023 guideline, and that is the same terminology you are using in recent one also. In step 5, oral short term low dose steroid like prednisolone 1 to 2 mg per kg we can give whenever there is severe exacerbation or symptoms are more. Step 5, हेलो सर मैं क्लास में हूँ सर, 10 o'clock के बाद आ पाऊँगा ओपीडी से. हाँ सर मैं क्लास में हूँ, 10 o'clock के बाद ओपीडी आ पाऊँगा सर. हाँ ओके. So step 5, if the symptoms are still uncontrolled, then we have to look for phenotypic assessment plus higher dose inhaled corticosteroid plus LABA or add-on therapy. So higher dose we can increase more inhaled corticosteroid, or you can use the add-on therapy. Now we can use biologicals or anti-IgE, that is called omalizumab, or anti-interleukin 4R or interleukin 4 receptor or interleukin 5. So these dupilumab like omalizumab, this drug we can consider at a step 5 is if it's not controlled with the help of step 4 drugs. And reliever is always the same, low dose inhaled corticosteroid plus formoterol. So now coming to the prescription for Arpit. Arpit requires a step 2 treatment, MDI with a spacer with no mask because he is more than 5 years of age. Controller drug we have budesonide 100 microgram twice a day through MDI and a spacer for a minimum period of 3 months. Reliever drug salbutamol inhaler 1 to 2 puff as required, and treatment of comorbid condition like Arpit was suffering from allergic rhinitis also. So we can use levocetirizine for 7 days and mometasone nasal inhaler for 2 months. So this is for treatment of comorbid condition. We can advise avoid triggers, peak flow monitoring at home, symptoms diary, written asthma action plan, and follow up visit after 1 month. So okay, so last bench ready रहना, अभी पूछा जाएगा, ठीक है. Next question. So now coming to this GINA classification, the same thing we have discussed. So children 6 to 11 years, all this we have already discussed for Arpit. So this is the same thing is classified into asthma action plan and step 4 and step 5, which we have discussed already. So we are not discussing again. Now coming to the management of asthma, children 12 years and above. So now coming to the Sanjana. Sanjana is a 14-year-old and weight of 57 kg, height of 146 centimeter. She has been hospitalized for wheezing about 3 to 4 times in last 6 months and frequent midnight visit to emergency room. She has been referred to you after an acute episode and on low dose inhaled corticosteroid and frequent SABA therapy for about 4 weeks. And she uses MDI without a spacer. She is still coughing most of the days in a week and has to get up at night coughing 2 to 3 times in a week. And she is not participating in sports and she is missing her school sometimes. So how you are going to assess संजना? लास्ट बेंच, हाँ चलो कर बताओ क्या प्रॉब्लम हो रही है संजना को, कैसे मैनेज करोगे? लॉन्ग एक्टिंग, सो तुम सल्बुटामोल की जगह फॉर्मेट्रॉल कर दोगे, साबा की जगह लाबा कर दोगे, यही बस इतना, दैट्स ओके। और भी कुछ है मिसिंग? आईसीएस का डोज बढ़ा दोगे, ओके। और कुछ? और कुछ छूट रहा है इसमें? एनीथिंग मिसिंग? शी इज यूजिंग एमडीआई विदाउट ए स्पेसर, ये इंपॉर्टेंट है, लास्ट क्लास में डिस्कस हुआ था। लास्ट क्लास में डिस्कस हुआ था अगर एमडीआई विदाउट स्पेसर यूज करेंगे तो क्या होगा, एयरवेज में कितना डिपोजिशन होगा, ओरोफेरेंजियल डिपोजिशन कितना होगा। सो अगर स्पेसर यूज नहीं कर रहा है कोई बच्चा या बड़ा या बूढ़ा, देन द इफेक्ट ऑफ एमडीआई will be more in oropharyngeal, deposition will be more in oropharyngeal, not in respiratory tract, which we want. So इसको भी तो ठीक करना है, चलो बैठ जाओ। So initial assessment we have to look for level of control, then we have to look for future risk of adverse outcomes. In this we have to look for risk of future exacerbation, risk of persistent airflow limitations and the medication side effect. So if we see the level of control in case of Sanjana, almost all symptoms are there, so her symptoms are uncontrolled. She is already on low dose inhaled corticosteroid with SOS salbutamol MDI, but her symptoms are absolutely uncontrolled. So risk of future exacerbation we can see based on what are the modifiable risk factors, like uncontrolled asthma symptom we can modify, low lung function we can modify, psychological problems and poor adherence we can modify, seasonal flare-ups we can modify with our asthma action plan, comorbid condition we can treat, exposure to irritant and triggers which we can treat. But these, like if the patient got intubated or PICU admissions, severe exacerbation requiring hospitalization, these we cannot modify. These symptoms is going to deteriorate this child. So drugs in asthma we can see the relievers option are beta 2 agonist, this is the salbutamol or terbutaline, and anticholinergic ipratropium. Ipratropium mechanism of action is different than salbutamol, and ipratropium is basically acting on long airways and small airways, salbutamol is acting more. So anti-inflammatory reliever, so this is the term, new term again in the GINA, anti-inflammatory reliever. So this was the reliever, now you are adding anti-inflammatory also in this, so this is called anti-inflammatory reliever. If you are using budesonide plus formoterol, then this is called anti-inflammatory plus rapid acting LABA. So formoterol is LABA and budesonide is anti-inflammatory. LABA long acting, but it's rapid acting. Controllers option we have budesonide plus formoterol combination. This is also anti-inflammatory reliever, but this has controller. This is for controller. Inhaled corticosteroid alone without formoterol, without salbutamol, like budesonide, fluticasone, beclomethasone, tiotropium, and leukotriene receptor antagonist, like montelukast. So maintenance and reliever therapy, that is called MART. The same MDI we are using for maintenance and also for reliever. Use of budesonide and formoterol as reliever or maintenance therapy. Very low dose, these are the 100 microgram budesonide is very low dose, and 200 microgram is low dose. So maximum recommended dose of budesonide plus formoterol combination in a single day is 22 microgram of formoterol, that is a 12 puff of Foracort, or 48 microgram below 8 years. So for more than 8 years 22 microgram, and below 8 years it's a 48 microgram. So 12 puff for adults and 8 puff for below 8 years. Rinsing of mouth is not required. Advantage of MART is greater reduction of severe exacerbation, lesser cumulative steroid dose, and lesser use of oral corticosteroid, lesser emergency department visit, and better symptoms control can be achieved with MART. So this is for more than 12 years. Starting treatment, assess confirm the diagnosis, symptom control, comorbid condition, this the same thing we are discussing again. and then track 1. Track 1 is a preferred controller. Track 1 is a preferred controller we have to look for, and if we have alternative option, then we can go for track 2. So, if symptoms are less than 4 to 5 days in a week, then step 1, that is the as needed low dose inhaled corticosteroid plus formoterol. Budesonide plus formoterol combination we can you can use like as needed, as required, like intermittent conditions. Symptoms are persistent most of the days or nighttime awakening. Nighttime awakening is not in this not there. Means it's a nighttime awakening with symptom most of the days, once a week or more. Then low dose maintenance inhaled corticosteroid plus formoterol. So we have to use continuous low dose maintenance inhaled corticosteroid plus formoterol, and in step 4 the same steps are there in previous 2 also. Daily symptoms, nighttime awakening, once a week or more, and low lung function has been added in this step. So here apart from these symptoms, there is lung function is also affected. If we do this spirometry, then FEV1 FBC ratio or FEV1, these symptoms may be reduced, the function may be reduced. So in that case, we can use medium dose maintenance inhaled corticosteroid plus formoterol. And in step 5, again we have to look for phenotypic assessment plus biological therapy like omalizumab or dupilumab, and consider high dose inhaled corticosteroid plus formoterol. So based on this, we can decide which inhaled corticosteroid, what is the dose of inhaled corticosteroid, what is the reliever option, and reliever option is always same for more than 12 years, always same MART we have to use, same as inhaler, same as reliever, and same as maintenance. So looking at Sanjana, she has symptoms for most days in a week. She wakes up at night due to cough more than twice a week. She does not take part in sports, misses school, so that is called limitation of activity, and she has to take salbutamol inhaler frequently, and symptoms are uncontrolled. Budesonide 200 micrograms she is taking without a spacer. So the most important point is here we have to correct the device. We have to use a spacer in case of MDI, and treatment of comorbid condition like obesity, which we have seen in the first slide, and she is also advised to undergo spirometry as early as possible. So the same thing we are again looking at adult and adolescent more than 12 years, the same track 1, step 1 and 2 based on the symptoms control, and the same review, assess and adjust cycle will continue, the same which we are discussing. Now in case of Sanjana underwent a spirometry, FEV1 was reduced to 80% of the predicted value, and FVC was 98%, that is normal. FEV1 FBC ratio is 81%, and flow volume graph show concavity. If there is cupping of the graph in the flow volume graph, that indicates obstructive airway disease. So after 400 microgram of salbutamol, her FEV1 increased to 96%, and that indicates 20% improvements, more than 12% improvement, suggestive of asthma-like conditions. So prescription for Sanjana, again device MDI with a spacer. Other alternative options are breath actuated inhaler or DPI, but most effective is MDI with a spacer. Controller drug we can use budesonide plus formoterol, 1 puff BD for 3 months, and reliever drug the same combination we can use for reliever also, this is called MART. Other reliever option is salbutamol, that is inferior option and should not be used alone as reliever. The current recommendation suggests should not be used as alone as a reliever, especially more than 5 years of age group. Written asthma action plans also should be given to manage flare-ups. Avoid triggers like maintain the symptom record, asthma diary, daily peak flow reading we have, the Sanjana has to take. Treatment of obesity is also important, and review after 2 weeks. Sanjana remains uncontrolled even after 2 weeks. 2 week के बाद भी इसका symptoms uncontrolled है. Then क्या करोगे? Again check for diagnosis. ऐसा तो नहीं कोई diagnosis miss कर रहे हैं, कुछ alternate diagnosis तो नहीं है. And check the following: dose, device and delivery. Dose सही है कि नहीं, device सही है कि नहीं, delivery सही है कि नहीं. Triggers, any other triggers which we are not which we have missed, and adherence to the treatment is there or not. So reasons for non-adherence: intentional. Sometimes the children or parents they are not accepting the diagnosis, and they feel sometimes better than they stop treatment. Fear of side effect and addiction is also there in sometimes, so they used to avoid the inhalers. Fear of stigma, again using of inhaler at public places, they always there is a stigma. And cost, sometimes cost is also a problem. Unintentional, they forget treatment, poor supervision, they do not understand the regimen which we have advised for Sanjana, misinformation, information was not correct, and the canister has become empty, and they are using the same canister for treatment. So, Sanjana needed DD adjusted treatment. Family and patient education is important. We have to explain the asthma, uncontrolled asthma and its consequences, need of inhalation therapy and devices, reinforce the need for adherence, and the trigger avoid the triggers. Correct use we have to explain at every visit. Advise diet and lifestyle modification to address her obesity, and here we can wait for some times because the adherence and everything was not correct. So, we can wait for response to treatment, and we can advise reduction of obesity and then wait for response. Now, again she has come after 6 weeks and she is now adherent. Now, she is taking the treatment perfectly, and mother is also supervising her therapy, but she still woke up at night due to coughing and wheezing frequently. So, symptoms are not very much controlled. Then check for diagnosis, look for differential diagnosis, look for comorbid conditions, check the following like 3Ds, dose, device and delivery, triggers, adherence. These everything, if everything is correct, then step up the inhaled corticosteroid. So, if everything is correct in the next visit, then you can increase the inhaled corticosteroid dose, drug dose and regimen both we can change. So, same step up we have to go now, we have to reach at the step 4. Step 3 तक तो हमने कर दिया था संजना में, step 3 में भी control नहीं था, then we have to go for step 4 and then further step 5. So, assessment on each visit, level of control and future risk of adverse outcome, risk of persistent airflow limitation, medication related side effect. So, daytime symptoms, nocturnal symptoms, activity, reliever use, these 4 symptoms we have to use. We have to check for whether the symptoms are controlled or not, which we have discussed. Daytime symptoms, nocturnal symptoms, activity limitation and use of reliever, how frequent. Adherence and technique, asthma diary and peak flow meter we have to monitor. Environmental control and avoid the triggers. Medication side effect, parental concern and counseling, these things we have to take care at each visit. So, on a subsequent visit, Sanjana parents were asking if there was an objective way of monitoring her. Can we predict an attack and start early treatment? And the mother has also some query regarding spirometry. So, कैसे इसको आंसर करेंगे? Can we predict asthma exacerbation before the onset of symptoms? मैंने बताया था लास्ट क्लास में. Anyone? So, you can use the peak flow meter, not necessarily spirometry. Peak flow meter is a 200 rupees device, a simple technique, and here she has to measure his peak flow reading every day, and if the readings are coming down, that means she is going to get acute exacerbation very soon. So, we can advise regular use of peak flow meter and spirometry also. This is a good tool to predict impending flare compared with her personal best. The best the best reading was something like 500, now it is coming down to 400, then the chances of acute exacerbations are more. So, it is basically a clinical things, and the symptoms diary we have to maintain, and spirometry we can do annually, we cannot do spirometry daily. So, peak flow meter is a simple device, they can perform on daily basis, and spirometry has to be done annually to predict the severity of asthma and to look for risk factors. Again, the parent has some complaint like she always get into trouble whenever she catches cold or other respiratory infection, whenever she is getting viral infection, URI, she is getting into trouble, and can we give her vaccine to reduce her frequency of symptoms? Again, this is the same the questions the parent will ask. And again, the immunization for children, influenza vaccine is we can advise, this is a recommended vaccine for children with asthma, that if even a 50% reduction in the URI episode by influenza, that helps in reducing the exacerbation. So, that can be administered in all children with asthma. Pneumococcal vaccine, no special recommendation, the same IP protocol or the same universal immunization protocol has to be followed for pneumococcal vaccine. There is no different protocol for asthma. Sanjana and Arpit both are doing well with regimen, and the parents, the concerns are what next? Can this be controlled? Can this be cured completely? So now, in first we will discuss if the symptoms are well controlled in last 3 months, then we have to step down. So we have to step down means we have to reduce the you have to reduce the inhaled corticosteroid dose by 50%, 25 to 50%, while continuing formoterol in combination. Suppose budesonide you are using 200 and formoterol combination, then you can reduce Foracort 200 to Foracort 100. And when control is maintained, reduce inhaled corticosteroid till the low dose is reached, and then switch to inhaled corticosteroid formoterol, switch to as needed maintenance therapy, as needed MART. While you अगर सपोज ये कॉम्बिनेशन पर था तब, लेकिन सपोज केवल बुडिस्टाइड पर है, then 25 to 40% reduction at every 3 month interval, and the control achieve हो जाए low dose inhaled corticosteroid पर, then what you have to do? We have to switch for once a day budesonide therapy, or better alternative is to as needed basis, as needed low dose inhaled corticosteroid plus formoterol as needed, like intermittent asthma like symptoms. Choose a suitable time for a step down, especially if the symptoms are more common in winter, more common in rainy season, more common during if the children is going for vacation. That time we should not step down, and we have to choose appropriate time for a step down. Well controlled asthma, stopping treatment. Good control continues on once a day low dose inhaled corticosteroid plus formoterol. Then a step down to age appropriate step 1 treatment. Above 12 years, budesonide plus formoterol inhaler once as needed basis. 6 to 11 years, low dose inhaled corticosteroid whenever SABA is taking, and under 5 SABA as per need. So SABA is MDI salbutamol you can take as needed under 5, but above 5 years you have to use inhaled corticosteroid whenever you are taking SABA or LABA. Trigger the avoidance factor, avoid the trigger factor, retain home management plan, follow up 3 to 6 monthly for 1 to 2 years, and also counsel regarding the possible future resumption of controller. अगर दोबारा होता है तो controller we have to start again. This has to be counseled. ऐसा नहीं है कि एक बार ट्रीट हो गया तो दोबारा नहीं होगा. We have to counsel that asthma cannot be cured, but that can be controlled 100%. 1 year later, Sanjana stays well and has a step down of therapy. She is well controlled on low dose MART for once a day for 3 months. At one of the visits, the parents are she can be cured. So this is we are discussing again and again. This asthma cannot be cured. Only we can achieve the good control. So now coming to the another case, Salis, 7-year-old with seasonal asthma symptoms, and he is in trouble every year during winter, and but the diagnosis is confirmed by looking at his past records. So how in this case, this is the seasonal asthma. So management is what the management you are going to advise for Salis. We cannot give MDI Foracort MART therapy for a whole year. So what we can do, we can advise MART 2 weeks prior to anticipated onset of symptoms and stop 4 weeks after the season. So at that particular season, we have to cover 2 weeks before and 4 weeks after, and we encourage indoor activity during such season. Especially if he is getting during the rainy season, we can start the MART therapy before 2 weeks and after 2 weeks, and avoid outdoor activities during this time. Daphne plays inter-school basketball, and every time he starts his game, he is wheezing within minutes. So the first case was seasonal asthma. This case is exercise-induced asthma. So क्या करेंगे इसको? Non-pharmacological approaches we will advise first, like warming up. कोई भी गेम डायरेक्टली स्टार्ट नहीं कर देना है, थोड़ा वार्म अप करके एक्सरसाइज जैसे करते हैं उसमें वार्म अप करके फिर स्टार्ट करना है. अवॉइड एक्सरसाइज ऑन कोल्ड मॉर्निंग में एक्सरसाइज नहीं करना है. नोज ब्रीदिंग को प्रेफर करना है, स्लो डीप ब्रीदिंग, and choice of game also we have to select for. So exercise induced asthma management is reassess the asthma control, watch for under reporting of symptoms, and need for step up of inhaled corticosteroid also we have to look for. Daily montelukast may also be considered. But before exercise, if you want to prevent onset of wheezing or bronchoconstriction, then you can give 2 puffs of inhaled SABA or Foracort 15 to 30 minutes before plant exercise, and after exercise you can give again 2 puffs of inhaled SABA or Foracort inhaler as per needed. So exercise induced bronchoconstriction commonly occurs during and after exercise, and other feature of asthma may be absent in these cases. So exercise is the trigger which has to be overcome, and that mostly that cannot be avoided. Now coming to the immunotherapy, this is the more discussing topic. So allergic immunotherapy cannot be recommended as a single therapy for asthma. Asthma the treatment is which we are talking for last 2 days, and immunotherapy may be considered in a child if there is some comorbid condition along with asthma. If the asthma के साथ में suppose the child is also having allergic rhinitis as a comorbid condition, then GINA 23 recommends sublingual immunotherapy as an option in children above 12 years. So sublingual immunotherapy for asthma if the child is having associated allergic rhinitis above 12 years of age group and on step 2, 3, 4 of treatment, then we can try sublingual immunotherapy in these cases. But the spirometry findings should be almost normal, not normal, but it's in a relatively better shape. So FEV1 should be more than 70%, and screen prick test is mandatory to identify the allergen against which we have to give the sublingual immunotherapy. Basically, we are giving the antigen in increasing doses to sensitize the child against these allergens. So allergens को पहले आइडेंटिफाई करना पड़ेगा कि किस एलर्जन से इस बच्चे को एलर्जी होती है. So we have to do the skin prick test first before, and once we have identified these 4 or 5 in the list are most common allergen which is causing problem in this child, then we can give immunotherapy with sublingual route. Another option is subcutaneous also. In previously the subcutaneous route was using for a long time, but now sublingual is preferred. So coming to Mrs. Saab brought her 8-year-old on a very busy clinic day, and diagnosis is confirmed and advised her the inhaled steroid, and she does not follow up. So diagnosis बना दिया आपने, उसको inhaled corticosteroid बता दिया और घर भेज दिया, and सब चीज़ ठीक किया, बट वो फिर किसी और डॉक्टर के पास चली गई और ट्रीटमेंट लेने के लिए. So what was the problem? Counseling. So at the first meeting you have to counsel the parents, and just prescribing any drugs is not enough, because asthma is a treatment. Asthma treatment is always required detailed counseling, detailed technique, explanation of the technique, side effects, and the compliance to therapy also we have to ensure. So now coming to the asthma exacerbation, the last part, the management of Arpit and his friends, we will discuss the flare up. So Arpit decided to help his mother during Diwali cleaning, and soon he starts coughing continuously. Mother started the treatment as per asthma action plan. So home management which we have advised Arpit during the discharge. So she has given SABA short acting beta agonist salbutamol 4 to 6 actuation through MDI with aspiration. Only one actuation at a time is preferred with a gap of 1 minute, and may repeat every 20 minutes for maximum 3 times. If inadequate response, start first dose of oral steroid and consult the doctor. So this has to be mentioned in all asthma action plan. If any child is getting acceleration, then we have to advise this combination. So mother has given the treatment as prescribed in asthma action plan and has come back to the pediatrician. So in the primary care clinic, we have to inquire about the onset of the breathlessness, on regular controller Arpit is there or not, relievers were taken or not, what was the response, what was the trigger, like the Diwali clinic. So basically dust mite, that was the most common factor that triggered his inflammation or bronchoconstriction. Previous flare up also we have to look for whether his asthma symptoms were well controlled or not. So on examination, Arpit has respiratory rate of 28, that is almost normal, with some accessory muscle use, comfortable and able to talk in sentence in expiratory wheeze. So 28 is like some in moderate more than the normal. Saturation is 96% room air. So क्या करेंगे? So this is the classification of pulmonary score. So asthma, Arpit is more than 6-year-old. So we will follow this respiratory rate cutoff. So this is a pulmonary score we have to remember for all management of acute pulmonary exacerbation or acute severe asthma. So less than 6 years, the cutoff starts, respiratory rate cutoff starts from 30 to 60, 30, 31 to 45, 46 to 60, and more than 60. But if a child is more than 6 years, then we have to follow the cutoff of less than 20, 21 to 35 1 score, 36 to 52 score, and 3 if more than 50 respiratory rate, then we have to give a score of 3. So Arpit has 28 respiratory rate, so it's coming into the score of 1. Wheezing, we can see in the Arpit there is terminal wheezing, not whole expression. The wheezing is not involved in whole expression, but if wheezing involved in whole expiration and inspiration both or silent chest, then it's coming into the score of 3. So terminal wheezing is the score 1, expiratory whole expiratory wheeze is 2, and throughout the respiratory cycle inspiration and expiration both or silent chest in 3. Now use of accessory muscle, if there is no use of accessory muscles, then 0. If you have some doubt like nasal flaring or suprasternal retraction, some doubt you have there, then it's a 0.1. If it's a apparent, it's apparent use of accessory muscles of respiration, then score of 2, and if it's a maximum use of accessory muscles like in severe distress like feature, then it's a score of 3. So all children with a score of more than 6 should be managed in pediatric ICU. This is important for ICU admission cutoff, and a score of 0.33 is mild exacerbation, a score of 4 to 6 is moderate exacerbation, and a score of more than 6 is severe exacerbation. So this will come as a separate question in your exam, management of acute severe asthma or acute severe exacerbation, or how you will classify asthma exacerbation. So this is the classification of asthma exacerbation: mild exacerbation, moderate or severe. You can get a case scenario like Arpit, Sanjana or whatever, and you have to diagnose the condition. You have to write the complete diagnosis: asthma with acute severe exacerbation or acute moderate exacerbation or acute mild exacerbation, and then all symptoms are based on control symptom, whether the symptoms are well controlled, partly controlled or uncontrolled. So this is the complete diagnosis, and then you have to start writing your management. So you will get in exam all the case scenario based question only in long answer question, and you have to classify, define, write down the complete diagnosis based on the pulmonary score, also classify the severe exacerbation or moderate exacerbation or mild exacerbation, then you have to start the treatment. So for Arpit, management in primary care, he is in primary care, not in tertiary care center. So Arpit in pulmonary score is 3, mild flare up, treatment advised are inhaled SABA, which we have advised, and continuous salbutamol inhaler. Oral prednisolone already has been started 1 mg per kg per day for 3 to 5 days, and budesonide formoterol dose increased. So we have to step up because the child has got acute mild exacerbation. So we have to step up the management. We have to step up like 200 microgram twice a day for 2 weeks, and Arpit was asked to follow up after 4 days. Arpit was doing well on his treatment at follow up, so we will continue this treatment. Now coming to the another patient, Aradhya, 9-year-old girl, came middle of the night. She is proceeding to casualty, and what we have seen, respiratory rate of 40 per minute, suprasternal recession and wheeze throughout expiration. So whole of the expiration is full of wheeze with respiratory rate of 40 per minute, and suprasternal retractions are there. So classification again more than 6 year, this is the respiratory rate, whole of the expiration wheezing is there, and suprasternal retractions are apparent. So this score is 6, it's not more than 6, it's a 6. So emergency room में क्या करेंगे, we'll give salbutamol. If saturation is more than 92%, then we can use MDI with a spacer, 4 to 10 puffs every 20 minutes for 1 hour, and if saturation is less than 92%, then means कि child is requiring oxygenation also. So always give nebulization with the help of oxygen. So oxygen driven nebulization is preferred. Like वो जो हमारे पास नेबुलाइजर मशीन होती है उससे अगर नेबुलाइज करोगे तो उसमें ऑक्सीजन तो होता नहीं है. सो अगर किसी को हाइपोक्सिया है और उसको आप सिंपल नेबुलाइज कर रहे हैं तो एक तो नेबुलाइजेशन से ड्रग डिलीवरी सबसे लेस होती है, एमडीआई विथ एस्पेसर से भी कम होती है, प्लस चाइल्ड हाइपोक्सिक है. सो अगर आप ब्रोंको डायलेट करेंगे एंड ऑक्सीजनेट नहीं करेंगे देन वेंटिलेशन परफ्यूजन मिसमैच होगा. सो वेंटिलेशन टू अवॉइड वेंटिलेशन परफ्यूजन मिसमैच यू हैव टू गिव ऑक्सीजन ड्रिवन नेबुलाइजेशन. ऑक्सीजन के ट्यूब से ही या सिलेंडर या फिर जो वॉल में ऑक्सीजन लगा हुआ है सेंट्रलाइज ऑक्सीजन, उसके हेल्प से ही आपको नेबुलाइज करना है. यू कैन नॉट नेबुलाइज विदाउट ऑक्सीजन इन दीज केसेस. सिस्टमिक स्टेरॉइड वी हैव टू स्टार्ट एज अर्ली एज पॉसिबल. कंटिन्यू असेसमेंट फॉर 4 to 6 hours. इफ गुड रिस्पॉन्स pulmonary score less than 3, then decrease nebulization. But Aradhya does not respond to this treatment, and 1 hour later her respiratory rate increased to 48 per minute, and now the child got admitted. सो वार्ड में क्या करेंगे, ऑक्सीजन कर देंगे, आईवी या ओरल स्टेरॉइड जो भी पॉसिबल है. स्टार्ट आईवी लाइन, साबा नेबुलाइजेशन, इप्राट्रोपियम नेबुलाइजेशन ऑल्सो वी कैन स्टार्ट टू कवर द लार्जर एयरवे. मॉनिटर SpO2, pulmonary score to be reassessed frequently, and this thing X-ray chest, serum potassium, CBC that also we have to look for. अगर वो इम्प्रूव हो रही है then we'll wait, continue observation for 6 to 8 hours. अगर worsening है then we have to intensify our treatment and oxygen has to be given. सो क्या इंटेंसिफाई कर सकते हैं, अब इसके बाद क्या कर सकते हैं. इनहेल तो सारा मेडिसिन दे दिया, स्टेरॉइड दे दिया, ऑक्सीजन ड्रिवन नेबुलेशन दे दिया. नाउ वी हैव For acute severe exacerbation, we have magnesium sulfate, IV terbutaline, but that has to be given under cardiac monitoring. Aminophylline, if terbutaline is not available, and the recommendation is give bolus first and then continuous IV infusion. Consider blood gas, ABG has to be done to look for CO2, and consider transfer to PICU facility. So, these are the drugs for like salbutamol nebulization dose is 0.15 mg per kg per dose, but the minimum dose is 2.5 mg, that has to be remembered. Suppose any child with 4 kg has come in your OPD and you are trying to nebulize this child and you are giving 0.15 yani 0.6 mg only salbutamol you have given in nebulizer box, nebulizer chamber, that has to be at least 3 ml fluid must be there to generate vapor. So, अगर आपने क्या किया 0.6 mg salbutamol डाला और 3 ml नॉर्मल सलाइन डाल दिया, वो तो इतना डाइल्यूटेड रहेगा कि वो इफेक्ट ही नहीं करेगा. So, that's why this recommendation is the minimum dose is 2.5 mg for all age group and the maximum dose is 5 mg. So, इतना minimum तो देना है, but dose is 0.15 mg per kg, but minimum dose is 2.5 mg. Ipratropium minimum dose is 250 microgram, methylprednisolone IV, magnesium sulfate, the dose is 25 to 50 mg per kg, terbutaline and aminophylline. These are the doses which you have to remember. So, अगर आपका रेसिडेंट डॉक्टर या आप पूछ रहे हैं कि एंटीबायोटिक दें या नहीं दें, so role of antibiotic is very limited, especially only in cases of purulent secretions or evidence of bacterial pneumonia. So, normally bacterial pneumonia केस में asthma exacerbation उतना common नहीं है, and purulent secretions then we can consider, but these have do not have a significant role in acute asthma management like antibiotics, mucolytic, cough suppressant, sedatives, chest physiotherapy and steam inhalation. These have no role. So, अगर acute severe asthma आया है उसमें ये सब चीज़ों में टाइम वेस्ट नहीं करना है. एंटीबायोटिक्स, म्यूकोलाइटिक, कफ सप्रेसेंट, दीज थिंग्स आर नॉट रिकमेंडेड. सीडेटिव्स नहीं देना है, चेस्ट फिजियोथेरेपी नहीं करना है, एंड स्टिमुलेशन नहीं करना है. एंड बैक्टीरियल इन्फेक्शन आर नॉर्मली नॉट एसोसिएटेड विथ आस्मा. सो द कॉम्प्लिकेशंस मे बी देयर लाइक एटेलेक्टेसिस, न्यूमोथोरैक्स, न्यूमोमेडिसिनम, सबक्यूटेनियस एम्फाइसीमा, cardiorespiratory failure, secondary bacterial infection, and some complications related to therapy. So, 36 hours later, Aradhya is showing signs of improvement, and on further questioning, she slept well throughout the night. Mild tachypnea, respiratory rate has come down to 24 per minute. Wheezing only in terminal phase of respiration. Earlier, it was whole of the expiration, and now she is asking whether we can discharge. So, again, discharge से पहले step down तो करना पड़ेगा, जो भी आपने intensified treatment किया था. The principle is last in first out. So, terbutaline, aminophylline अगर आपने start किया, the data has to come out first. Discontinue ipratropium nebulization in next 24 hours. Reduce SABA to 2 to 4 hourly and then 6 hourly, and replace IV steroid with oral steroid. Now, we can discharge this kid Aradhya. So, discharge criteria is pulmonary score less than 3. So, should sleep. There should not be any nighttime awakening symptoms. Eating well. Should look comfortable, and not on any continuous infusion or receiving SABA like 6 hourly doses. Then only you can discharge for home management, and again send home with asthma action plan and review of current treatment strategy. So, क्या एडवाइस करोगे? डिस्चार्ज प्लान अगेंस्ट दी सेम आजमा एक्शन प्लान लाइक साबा विथ एमडीआई स्पेसर 4 to 6 hourly till symptoms controlled. कंटिन्यू कोर्स ऑफ स्टेरॉइड फॉर 3 to 5 days. टैपरिंग इज नॉट रिक्वायर्ड. 3 से 5 दिन के बाद बंद कर सकते हैं डायरेक्टली. स्टार्ट डेली इनहेल कॉर्टिकोस्टेरॉइड इफ नॉट ऑन कंट्रोलर, और डबल द डोज ऑफ इनहेल कॉर्टिकोस्टेरॉइड फॉर 2 to 4 weeks. सो अगर कंट्रोलर पर नहीं था देन यू हैव टू स्टार्ट इनहेल कॉर्टिकोस्टेरॉइड, और अगर ऑलरेडी ऑन इनहेल कॉर्टिकोस्टेरॉइड था देन यू हैव टू डोज दी increase the dose. So, these are simple techniques like step up management, and plan follow up visit within 2 days. So, again one Raju 8-year-old with asthma has come in ambulance with oxygen by mask, true breathlessness to speak, sweating, agitated, dusky, on auscultation the chest is completely silent, no response to 3 doses of nebulized bronchodilator. So, क्या करोगे? So, these are the red flag signs of asthma: unable to talk or cry, feeble chest movements, fatigue and exhausted, absent breath sounds, silent chest, cyanosis. Absent breath sound, silent chest means bronchoconstriction is so significant that you are not able to hear the respiratory sounds also. Cyanosis, oxygen saturation is less than 92% is a red flag sign. Agitated and altered sensorium means oxygenation is affected, that's why, or CO2 retention is there, that's why the child is agitated and in altered sensorium. All these are signs of hypoxia. So, these are the red flag signs. Oxygen to be started, monitor SpO2, injection terbutaline subcutaneous. If not available, then you can give adrenaline as a replacement of terbutaline as a subcutaneous dose. Inhaled SABA plus ciprofloxacin has to be started. Injectable steroid and IV fluid therapy, inform ICU and start ICU management. So now almost all the part has been finished, all the age group asthma management and acute severe management. Now the 3 slides for summary slides. Like asthma is a chronic inflammatory disease which we have discussed. In preschool recurrent wheezer, one need to rule out alternative condition other than asthma. All asthmatic do not wheeze and all wheeze may not be asthma. So ऐसा जरूरी नहीं है कि हर आजमा में वीज होगा ही, और ऐसा भी नहीं है कि वीज लेके कोई बच्चा आया है तो उसमें आजमा ही होगा. Many children outgrow their early childhood wheezing. That's why under 5 children we are not classifying asthma. We are classifying as under 5 wheezer with low probability, some probability or high probability. In preschool recurrent wheezer, these 4 things are. These are simple things like history of allergy we have to ask for, family history of asthma we have to ask for, frequency and severity of symptoms we have to ask for, and interval symptoms, like interval symptoms in between child is symptomatic or not. This we have discussed in last class also. So these 4 things we have to ask, these simple 4 things we have to ask, and that will indicate if the child is having high probability of asthma is there or not. If the symptoms are present, trial of inhaled corticosteroid can be given for 3 months, and diagnosis of asthma is always clinical, but spirometry is strongly recommended above 6 years of age. Adequate time should be given for patient counseling, education and device demonstration. At every visit, technique of inhalation and adherence should be checked. This is the key of success of asthma management. Level of control should be assessed by symptom control over last 4 weeks, means last 1 month में उसका symptoms कैसा controlled है, and that decides the long term management. Salbutamol should not be used alone as a reliever, जो मैं बार बार बोल रहा हूँ. Now the recommendation GINA guideline has changed. Use inhaled corticosteroid along with salbutamol as and when required. So जब भी अगर सपोज किसी को इंटरमीडिएट आजमा लाइक सिम्टम्स है और सल्बुटामोल ऐसे ही ले रहा है, वो अब रिकमेंडेड नहीं है. यू हैव टू यूज कॉम्बिनेशन और यू कैन यूज बुडेसिनाइड inhalation and salbutamol inhalation combined as a rescue therapy. Inhaled steroid are the mainstay of management of long term asthma. Majority of children can be managed with low dose inhaled corticosteroid only. Risk factors and comorbid factors triggers has to be assessed regularly. Treatment should be a step up or step down after reviewing the patient response. So response to management, asthma control we have to assess at every visit. We have to look for peak flow meter reading, and then we can decide a step up or step down therapy. Provide asthma action plan at every patient visit to avoid flare up, and the important point is the drugs can control the asthma but cannot cure the asthma. Management of acute flare up summary, grading at a point of time by assessing the pulmonary score that we have discussed. Pulmonary score you have to write down in your exam if you are getting the acute severe asthma. Short acting beta agonist or budesonide plus formoterol MART inhalation. Systemic steroid, oxygen are the mainstay of acute severe exacerbation, and in most of the flare up MDI with a spacer is more efficient than nebulizer, which we have discussed, because nebulizer cannot effectively deliver the drug at respiratory tract than MDI with a spacer. Nebulizer used without oxygen at home may cause worsening of symptoms. So अगर सपोज किसी ने nebulizer यूज कर रहा है घर में विदाउट ऑक्सीजनेशन और उसको hypoxia है, then that may lead to worsening of symptom because of ventilation perfusion mismatch. In hypoxic patient, oxygen driven nebulizer should be used. Adherence to appropriate controller therapy helps in reducing the severe flare up, and provide written asthma action plan to every patient to avoid future flare up. And the devices, MDI with spacer is the most versatile device, and that is the most recommended device over other devices, and MDI should always be used with a spacer even in adult and adolescent and even in geriatric age group. So in asthma clinic, we have to we can counsel the parents with the help of these education material like these airways, how the asthma airway manifests like asthmatic airway, the bronchoconstriction and the smooth muscle and collection of mucus in the airway, and the posters on the triggers you can like infection, cigarette smoke, air pollution, pollens, molds, pet allergy. These things you can avoid in the home, and if you will control all the asthma with the appropriate management and acute severe exacerbation with the timely management, then all will remain well, and they will do better in the school, and the growth will not be hampered, and the lifestyle also we have to explain in this group. ये दे दीजिएगा।
कब से जो आ रहे थे अंकित अंकित को लेना है
हाँ
अंकित को देना है अंकित जो
हाँ हाँ जो अंदर होता है हाँ राजा राजा यहाँ
राजा
या उसको वहाँ पर रख दीजिएगा।